So welcome everybody to the CIN webinar on how to integrate substance use disorder treatment into primary care. This webinar features best practices to expand confidence and capabilities of primary care teams in treating substance use disorders. My name is Marie Hubbard and I'm the project manager for the California Improvement Network. For those of you that aren't familiar, CIN is a network of quality improvement leaders focused on innovation in healthcare. This CIN is funded by the California Healthcare Foundation and administered by Health Force Center at UCSF. Just want to call out the CIN Behavioral Health Action Group. It's a group of improvement leaders from CIN partner organizations that help to identify the need for more resources on expanding the capabilities of primary care teams in treating substance use disorders. They helped to create parts of this webinar and were integral in creating the need for the toolkit that we'll be talking about during this webinar. A few pieces of logistical information before we get started. Everybody is on mute except for our speakers. If you would like to ask a question, please feel free to use the Q&A box, which is located on the panel at the bottom of your screen. We'll try to get to as many questions as we can within the hour. This webinar will be recorded and we will also be sharing the PowerPoint in the recording with those in attendance after the webinar. Don't forget to visit CIN's website, www.chcf.org/CIN, to view all past resources, including a few other webinars on this topic. Now I'd like to introduce our facilitator, Crystal Eubanks. She's a Senior Manager of Practice Transformation at California Quality Collaborative. I'll now pass it off to you, Crystal, to get us started and introduce our other presenters.
Great, thank you, Marie. Good morning, everyone. Welcome. We're so happy to have you here and to share some highlights from our toolkit, but more importantly, some really incredible stories from peer organizations that have been working in this area of integrating substance use disorder treatment into primary care for some time. And so to hear about their journeys and kind of those lessons learned that we can all benefit from and learn from. So our two stories today, we have two wonderful individuals. From HealthRIGHT 360, we have Dr. Ako Jacintho, and from Ventura County Medical Center, we have Dr. Tipu Khan. And so they're going to share, the bulk of this is going to be sharing their stories and giving you the opportunity to pick their brains of those experienced individuals and pull out those tidbits that you can apply and adapt in your own organization. Before we jump into hearing their stories, we're going to do a little bit kind of an overview of the toolkit and what came out of the interviews that we did with key informants throughout California, which is really how do we pinpoint what the care team barriers are. This came into focus in a bigger discussion from our behavioral health work group as we tackle behavioral health integration, we really want to focus in on substance use disorder, and within that there really wasn't a lot to address. How do we support care teams through this, right? They're on the front lines, they're doing this work, and so how do we get to the root of supporting the people that are integrating these services? And within that, we'll share the journey kind of that we learned from all the organizations, and there's some really key strategies, and within that some very impactful change interventions. So we'll highlight the most impactful for you guys, and then hear from our peers. So we're going to take a moment to get a poll and get a sense of you guys in our virtual room. And so we wanted to ask you to think about your reasons for joining this session today, and really hearing what motivated you to take this time out of your busy day. Are you really focused on this because you know someone that's been impacted by addiction? Is it that it's important at your organization, you want to figure out what to do with it? Or maybe you're a care team member, and maybe you're just interested in learning about what's going on and hearing from other organizations. So Marie, if you could kick off that poll real quick, let us know your reasons, and you can pick more than one. Okay. Take 1 minute more. Okay, Marie. Let's see. I think you can all share the results. Okay, so an overwhelming majority of people said it's a really important issue in your organization. So I feel like we're all kind of in the same boat of really trying to tackle this and coming to the forefront of our priorities, our strategies, but really meeting our patients' needs. And then let me see, and we curious about other organizations, NQI efforts, great. So I think we'll work to meet those needs and your reasons for joining. Feel free to, as we go on, ask questions through the Q&A box, and Marie is going to tee those up for us and throw them out at us as we go along, but don't feel shy about reaching out. Okay, so we're very proud to share that we created a toolkit from our work and our interviews, and it is now available at the link at the bottom here. This is the front cover of it, and so for those of us, and Marie just shared that link in the chat box. Thank you, Marie. So if you want to go deeper beyond today, this is where all the information is. We're just going to do a few highlights. So, we had an advisory group, as Marie mentioned, but I really want to call out our key informant organizations. These were organizations that very generously volunteered their time and let me dig into what they're doing and asking a lot of questions and sharing their resources and both what worked for them and the things that didn't work for them, right? And being authentic and vulnerable and sharing some of the challenges that they're really going through. So I just want to call out the Alameda Health System, Bright Heart Health, HealthRIGHT 360, Golden Valley Health Centers, and Ventura County Medical Center. So if you want to dig a little deeper, here's the individuals and their links to their email addresses in the toolkit if you want to follow up. Okay, so jumping into care team barriers. We realized that as we tried to sort out how do you support the care team, we really had to dig into what were the barriers to them feeling confident and comfortable providing these services, right? And I realized some of that relates to individuals, right? A lot of that relates to individuals, who they are, what support do they need as people, as staff, but also there's leadership and there's systemic issues in the organization that also need to be addressed so that they feel supported and have the skills and the confidence to move forward. So we tried to call out the specifics of these, and I'm just going to touch on a few because there was a lot. But I asked, each of these organizations really had to hone in on what were the biggest barriers in their organizations, and devise strategies and plans and work around that. So the first step in doing this work is to do that self-assessment as an organization. So we realized that amongst the broader care team and thinking about ancillary staff, we heard a lot about just a misunderstanding of what addiction is and the risk factors. And this was related to some stigma that was still present, but it was really honing in on both understanding what patients were going through, understanding who was impacted, and then feeling safe about moving forward, both in terms of maintaining privacy and feeling comfortable interacting with patients, and knowing what integration would look like. Clinicians, there were also a lot of barriers, and I think some of this is related to the broader care team of understanding what's happening in the population, and some of substance use disorders may be underdiagnosed, and so honing in on that. And then really understanding medication-assisted treatment, that was a big gap, and there's so much evidence coming out and a lot of work around this, and so it was really about educating providers about what MAT, medication-assisted treatment, is, what it does, how it works, and how they can use it in their care with patients. And then with leaders, that there was, as you guys have pointed out in the poll, right, it's an important priority in your organization to how to integrate substance use disorder treatment, but there was a lot of fear from leaders about burdening care teams with more responsibility. We heard some of that, and really uncertainty about how to navigate some of the regulatory issues, whether it be billing, patient privacy, and so just unclear of how do they support, like what infrastructure needs to be built to support some of that. And then at the root of it was some misperception that it cannot be reimbursed or it's not financially sustainable. And we'll hear a little bit about that, but that there was a misperception about that. And so how might leadership look a little longer term out at that sustainability issue from the outset? And then our systems, no surprise to anyone, there are challenges with electronic health records still being a barrier, but there's a lot of things that we can do within the EHR systems just to make care provision easier for our care teams and to really train them up and utilizing the functionalities that are there. So as we kind of heard about all of these barriers, we found that there are really 3 strategies that were almost not exactly sequential, but 3 focus areas. And one was focused around shifting the attitudes of the broader care team, so including ancillary staff, clinicians, and leadership. So shifting the attitudes that were there so that they were open to change. For some organizations, they took a little bit more of an incremental approach, that after they shifted the attitude around addiction and patients is really understanding how it impacts the particular patient population that they're serving. So that awareness of its impact on the community, within the clinic, right? It's not necessarily new patients, it's the patients you love and know are struggling through this, and so how might they support them? And then as organizations made that shift and care teams were more open to the change, they were motivated to jump into it because realizing the impact on their patients and community, that how do you accelerate access to treatment? So that's actually the provision of the services, both in treatment, behavioral health support, case management, all those things. And within these strategies, there were some key tactics that we laid out. Here's like the action items that you would do, right? And so across all of them, there was a piece that successful organizations connected to the mission, right? Regardless if you're safety net or commercial, the mission of providing healthcare and making people healthier. So what were steps that could be done to connect to that mission? Successful organizations learned from others. They went out, they observed, they spent time in other clinics, they asked for pieces of information. So we have some resources there about where you can learn from others. They also gave clear direction to the care teams, both in terms of the strategy and where they were headed, but also starting to devise and design what those services were going to look like inside their organization and adapting what they learned from the others. They provided support in terms of infrastructure, training, and raised awareness, not just within the immediate care teams, but the broader organization and sometimes the community. Provided the training resources and invested in their care team members to really build those skills so they feel confident before they just jumped into it. And then clarifying the process was about workflows and what workflows can be designed, how to optimize workflows for efficiency, how to really use the EHRs in a way to make it easier or at least respond to regulatory requirements. And then lastly, this measuring the impact. So not just providing the services, but monitoring the data and that are these services effective? If not, how do we refine them and adapt that and really messaging and communicating the impact they were having in the community. So you'll see within each of these areas, we've detailed the action items and also some resources for you there. So there's lots more there. So as I said, just a recap of the strategies, right? Many organizations start with shifting attitudes, and it's really, as this quote says, eliminating stigma by changing the hearts and minds of care teams, right? So opening their perspective and being open to change. Some organizations then took an incremental step to increasing awareness and exposing care team members to patients along the spectrum of addiction, right? Understanding that right, that there's a wide spectrum of what it looks like, but basically humanizing it and connecting it to the patients they know and love, and understanding patient challenges and the patient perspective a little bit better. And then lastly, this accelerating access to treatment. I think we'll hear quite a bit of this today, but this evolution of what that accelerating access looks like, and it doesn't necessarily start out with a full-blown MAT program, right? That you grow it. really honing in on QI, the QI process, right? The model for improvement, a small test of change, learn, refine, right, as you grow and scale. So, right, this starts with establishing a small care team. Organizations then work to engage other PCPs in maintenance of medication-assisted treatment. And as they grew, more clinicians prescribing, reaching more patients, of transitioning that initial MAC care team that became experts into kind of like an internal specialty team to continue supporting the wider care teams. Okay, so another question for you guys to think about and help us kind of focus our discussion today is, when you think about your own organization, which strategy is top priority for you right now? So where are you in this spectrum, right? Maybe you're just considering integration and very early on, but maybe you're at the point of you're starting to shift attitudes. Maybe you've tackled that a bit and you're starting to increase the awareness of the patient population that's impacted, or maybe you're already in the accelerating access strategy. So Marie, can you pull that poll up, please? So let us know where you are, and we can tailor our focus for today. Are you ready, Marie? Big reveal.
We can get a few more. We're just shy of 50%. All right.
Oh, cool. Okay. So most of the group is actually at the point of considering access to treatment, and then the next group is in the very early stages. So I'm putting this challenge to our faculty here as they tell their stories and their journeys, that we can emphasize how to deal with the shifting attitudes and as well as the accelerating access to treatment. Well, thank you. Okay. Moving on. So within the toolkit, we have some stories from amazing organizations, and it's my pleasure to introduce two of them. We're going to kick it off with Dr. Tipu Khan from Ventura County Medical Center. And if you would just share a little bit about your own background, and then tell us, the high-level journey of your organization in this work.
Sure. Thanks, Crystal. And thanks, everybody, for joining in. So my background, I'm a family physician, so I am boarded in family medicine. I then did a one-year fellowship in obstetrics, so I've also been doing high-risk obstetrics. And then I was boarded in addiction medicine, so I'm also an addiction medicine specialist. I'm at Ventura County Medical Center. I'm one of the core faculty in our residency training program for family medicine. And I am also the program director of our primary care addiction medicine fellowship. Excuse me. So a little bit of background to what we did in our organization. A quick story is when I joined the organization, we weren't doing a lot of medication-assisted treatment. But essentially, we had maybe about 3 providers that were ex-waivered and doing medication-assisted treatment, but it was essentially for a handful of patients. Patients they either had inherited or patients that they had picked up from wherever else, but they weren't really open to a new panel. So I'd say that clinic had maybe a total of 5 patients on medication-assisted treatment, and there wasn't really a lot of management of substance use disorders, let alone screening, etc. So this was obviously an interest of mine coming in and something I had been doing in my own practice. So when I joined faculty, one of my goals was to expand the understanding and treatment of medication-assisted treatment, but as well as just general substance use treatment through our residency. And we wanted to start that by modeling it in our faculty clinic. So in our clinic, we started with myself just being open to taking new patients and bringing new patients on. And what we found was we were getting a lot of resistance from people within our organization. So mostly other physicians, so other faculty members or physicians who just didn't understand what medication-assisted treatment was, how buprenorphine worked, how naltrexone worked, etc., and had kind of the understanding that this is going to be like a methadone clinic, that by providing medication-assisted treatment, we're going to turn our primary care clinic into a methadone clinic. So the first thing we really had to kind of work through were the stigmas and the barriers and understanding of what medication-assisted treatment really is. And the best way we kind of approach that is really by just having a few patients come in. So I didn't open our practice originally at first to outside referrals. I actually removed myself from the the physician locator. So most organizations, SAMHSA, et cetera, have a physician locator where you can locate physicians in your area that have an X waiver to provide buprenorphine service. I removed myself from that. I said, let's just focus on our clinic alone. We know our incidence and prevalence rate of opioid use disorder. We know it's around 5%. We know we've got those patients in our system. They're there. They're not going anywhere. We just haven't identified them. Let's just focus on those patients. And so we did. We focused on those few patients that were already in our system, started identifying who they were by screening and then offering referral and treatment, and started treating them. And in doing so over the course of about a year, it took a while. It definitely was not a quick process. It took some time, but over the course of about a year, the patient care that other faculty members were seeing and staff as well, along with informational meetings that I was doing. So I was doing kind of informational faculty development on what buprenorphine is, what naltrexone is, what is medication-assisted treatment, et cetera, kind of breaking down those stigmas and barriers. And we did that for about a year, and right around the year mark, I think our people started realizing, oh, this really isn't what I thought it was going to be. This really is managing a problem that my patients already have and don't have anywhere to go. So that opened up the door for having a couple other of my partners, faculty members, get waivered to back me up. And I told them, hey, you don't have to see your own patients, but if I'm on vacation, can you just rewrite this prescription for me or fill the prescription? And they were happy to do that. And that grew to now we have about 15 faculty members. That grew to essentially about 80% of our faculty is now X-waivered. And probably about 50% of them see patients. The other 30% decided they just want to provide prescription coverage. But more importantly, that allowed us to teach that. And now every year we put on a course for our residents, that all of our residents get waivered. Our residents have their own practice panel as well for buprenorphine, and our attendings provide support. So again, all in all, it took about a year, year and a half for this to become what it was. And it really was patients, one patient at a time, and slowly introducing more patients and letting people see that it can be integrated in a primary care setting without having to turn it into a subspecialty clinic.
Great, thank you. If you have some questions for Dr. Khan, please put those in the Q&A. Anything that's coming, and then we're going to now hear from Dr. Ako Jacintho about HealthRIGHT 360's evolution. So, Ako, if you could introduce yourself, a little background, and then how your organization has integrated treatment.
Yeah. Hi everyone. Thanks for joining. So I should say at HealthRIGHT 360, I wear two hats. I'm the director of addiction medicine here, and I'm also the medical director of our residential programs. HealthRIGHT 360 is a behavioral health program and also has 3 federally qualified health clinics that provide medical care. So I am primarily working in one of the 3 primary care clinics that we have. And in that clinic, I do consultations for the PCPs within that clinic and the other clinics that are part of HealthRIGHT. I do peer reviews. One of the things that we've been really working on is trying to standardize our care for patients who are receiving MAP. I've created templates and do screenings, decide on which screening tools that we're going to use, provide education for the staff within the clinics on substance use disorders, and just provide overall support for them. I think when we were doing the poll, the 2 things that sort of came up was shifting attitudes and accelerating to treatment. So I can tell you a little bit about sort of my journey. I actually got waivered in 2005, and I was basically in a private clinic at the time. And, I had a patient who was a soccer mom, and she found herself addicted to prescription opioids. And she really wanted some help. And that's when I decided to look into getting certified in doing BUP, and then stumbled upon that, started practicing prescribing that. And And in 2012, I actually left that private practice and moved into the safety net with HealthRIGHT 360, where I could really focus on doing this work. I'm a family doctor, but also became boarded in addiction medicine, and really wanted to sort of shift to the sort of what I was seeing in this country around sort of the opioid crisis, and really wanting to address that more. So this is sort of how I made myself available. And, you know, we started here at HealthRIGHT just with me and a medical assistant, and sort of became, brought sort of my own sort of expertise from doing this in private practice to the other sort of 3 FQs that we have, and just really started to teach people about what my experience had been. By 2016, we had identified champions in all the 3 FQs that we have here. And we had a team of a medical provider with a medical assistant and with a nurse. Like I had mentioned before, we actually created templates. We use our eClinicalWorks. And so the templates that we created were really to help so that all of the clinicians that were doing this work would collect the same information and would provide the same standard of care. As well as the template, we also put in screening tools, so Expert, DAST, and the Audit C, so that the clinicians could use the same screening tools. And so what our team sort of look like now are just a provider, an MA, and a nurse. And like I said, they're champs at the different sites. And we have at one of our site, me and another provider that serve as sort of the core team, very similar to the sort of hub and spoke. We were sort of the hub, and we spoke out our expertise to the other clinics and the other providers if they need our help. The core team, which is me and another provider, in addition to the MA and the nurse, we also have an alcohol and other drug counselor and AOD counselor with us to provide that extra support for patients. I think the 2 sort of pearls that I wanted to bring, because I think for all the providers that are doing this work, you'll sort of hear a similar sort of journey of how they started and how other people started to sort of tag on, is 2 things. One, is that in this whole process, what I really learned about myself was how it sort of triggered my need to do my own sort of self-management around stuff like this. I like many of us, I come from a family, there's addiction in my family. I wanted to do this, but I didn't realize how much it was going to trigger for myself. And so one of the things that I want to sort of make note is that it requires some reflection. You might be triggered in some of this work. This is what I noticed. This is what other providers who have done this work in our organization have also noticed. And we really have tried to sort of work to support one another. We have these monthly meetings where we talk about cases, but we also reflect on how we are responding to these cases. Once a week, the other core provider that I work with, we meet just to sort of provide a little bit of support to one another around stuff like this. So that's the one thing, is about self-management. And the other thing is that, you know, this addiction is about, for a lot of folks, about trauma. It's how they cope with trauma. And so when you're bringing this into the primary care setting, you have to be really cognizant of that you might be really unleashing a lot of trauma stuff that patients may not have traditionally brought to you as a primary care provider. And so you're going to have to be prepared for that. And getting other staff members on board to work with you may be a challenge, because they might find that they're not necessarily prepared to take this on themselves. So just being mindful of that, supporting your care teams, and just recognizing your own self-management that's needed to do this work. So those are the 2 things that I wanted to sort of highlight.
Thank you, Ako. So we have a couple of questions, and please send in more. We're going to open this up for a little bit, just to open dialogue with our 2 faculty members. And so I think the first question is really talking about resistance among the care team. And so maybe I open up to you guys of what was differences in resistance between the broader care team members and the clinicians? And then how did you address that?
So in our system, and also with my experience with my other clinics I'd worked with, was pretty similar in that the physicians, as I mentioned, were really worried that it was going to attract a certain type of patient, that their panel would turn into a methadone panel, right? And kind of that old stigma of what medication-assisted treatment was, which we kind of talked about a little bit already. But from the rest of the care team, what we did notice was that other care team members didn't really understand what buprenorphine was or what medication-assisted treatment was at all. So their understanding of what it was to treat substance use disorder was relatively minimal. So their biggest concern when we rolled this out was essentially, what are we doing and how do we do this? What do I need to do from my standpoint as a medical assistant or as a front office or as the back office or the scheduler? So it really did help kind of walking through each piece of the puzzle and letting them know that, hey, from the front office standpoint, if a patient comes in, they might not look good. They might be in withdrawal when they come in. They might look sick. They might look anxious. This is part of the process of how they're feeling. So they're kind of priming them to what to expect. Same thing with our call center, letting our call center know, hey, when these patients call, these are patients that usually need to be put in within 24 to 48 hours because they're a hard patient to capture. And if they're ready to come in, we really need to make room and get them in. So we're going to block a same-day visit slot on my provider schedules as a protected slot for medication-assisted treatment or substance use disorder. So if that patient calls the call center, you can put them in directly that same day for that slot. And then in terms of our medical team, the MAs, et cetera, was really walking them through the process. And I gave them the same presentation that I use with my physicians. I used the same presentation with them and went over what buprenorphine is, the biochemistry, how it works, and what it does, and really brought them up to the same speed that I expected, our providers to understand it as well. And that really helped, I think, build empathy within the group and understanding what buprenorphine and what medication-assisted treatment look like, but also helped people understand what to expect when these patients come in not looking so good.
And Ako, how did you work towards cultivating that empathy and compassion among the broader care team?
Right. So there are a couple of things I think one was sort of asking the team what they needed to do this work. And a lot of them said that they just needed some training in de-escalation. And they also needed some training in how to recognize, they wanted to know, how do you know if someone is high, and high on what? And is it dangerous? So a lot of it was just giving them education about the different drugs that patients would come in and how they would typically present. The one that makes people very fearful is around meth. And because a lot of the patients, when they come intoxicated with meth, they can be really agitated, can go from 0 to 60, could be really paranoid. And so our staff are really fearful of this. So just providing them with some education, teaching them, doing some trainings on de-escalation. And then also what we did, because they were concerned about safety, is we hired a couple of safety monitors. So it's not security, but they're just safety, and they navigate patients. And so that actually helped our staff to feel a lot more comfortable that there was someone that could help navigate these patients, and they felt like they didn't have to sort of be burdened with this themselves. So the navigators are really great, and they help to de-escalate patients who are really high and sort of keep them safe. So that was part of our sort of strategy. And we have safety people in all of our sites.
And then on the kind of the other side of that, when there was a something that challenged a care team member, how do you handle that?
So for us, when there's a challenge around, a patient and their behavior or whatever it might be, feeling manipulated, or there's so many different things that come up. Typically what we do, our core team, we try to meet at least at least twice a month to sort of talk about these different cases, but often it's just dealt with on right then and there to sort of see what challenges have come up for the person, for the staff person, and see how we can reconcile those things. A lot of it is sometimes it's just fear with continuing to work with a patient, and how I can sort of mitigate some of that fear and that anxiety and teach them different ways of approaching patients or tools that they can sort of gather to sort of be more effective in their communication. So a lot of it's communication, and it's really challenging with patients with addiction because the level of likely intoxication that they might present with, or even levels of trauma and being triggered by certain things. So those are, I think, the differences that we sort of encounter with treating patients in our community with substance use disorders versus other medical problems.
Yeah, so it sounds like from both of you, this idea of peer support among the clinicians, peer support among the care team members, and how you build that into the system. Doesn't have to be super formal, but like you said, like if they need support right then and there, right?
And I do think that's a really important point to emphasize, is in order to make a program successful, no matter what the size of your organization, again, a large organization like what I'm doing with here at Ventura County Medical Center, or even some of the small organizations like FQHC I worked at before, it was just 3 of us as providers, is you really want everyone from front office to call center to back office to feel comfortable with what's going on and understand it, because if they don't, it's going to make the process that much more difficult, because they're trying to wrap themselves around their comfort level, let alone trying to be able to shift their focus to helping you develop this new program. So I just want to emphasize again, kind of like what everyone's saying here, is that we really want to make sure you get all the stakeholders and all the continuity levels of your team care involved and on the same page.
And it sounds like that the process of doing that starts with the education about addiction, the different substances, the treatments, before you start building the skills for patient interaction, right? Is that fair? Okay. Cool. Okay. Our next question is the role of medical assistants on the MAT team. And so how is that medical assistant different than other medical assistants? What's the role they play?
So the medical assistants on our MAT teams, or even with our core sort of MAT team and with providers who are the champs in the different sites, is that they know the use of the templates more than maybe the other MAs. We have these templates that we've designed specifically for BUP induction, BUP follow-up, for induction for someone who's coming with alcohol use disorder, induction versus follow-up, for nicotine. So we have these different templates, and so the medical assistants basically have become more versed in these specific templates and how to ask some of these questions around urges and cravings, and sort of the nuances of those specific questions, so we can get that data. So that's one difference, at least for that I noticed for us.
And interestingly, in our system, it's a little different in that because we are a residency clinic and a teaching clinic, our MAs, we don't have a specific designated MA that manages any of our substance use panels. So we don't have a specific MA that manages our induction clinic, et cetera. So most of what we do is actually geared from and supported through the residents. So our residents who are seeing the patient, they're the ones who are doing most of the screening. They're doing the induction follow-ups. They're doing the DAST and everything else that needs to get done. So our MAs are essentially just handing the packets to the patients, and the physician comes in and helps kind of walk them through it. And the reason we structured that in our clinic, again, is because we want our residents to understand it. And then obviously from there, they'll go to their own practice or join a group where then you can train your MAs, just like Ako was saying, have your MA kind of take over that role. But since we are an educational clinic, we wanted our learners to be able to understand the system well enough to go out and teach when they go elsewhere.
Great, thanks. Our next question, let's see, in the Q&A is, what are your thoughts on focusing on pain management patients first, prescribing Suboxone to treat their pain?
So I'll hop in real quick on this one, on our perspective on it. I think it's important to understand the legal implication of treating a documented pain disorder with Suboxone per se versus treating an opiate use disorder with Suboxone and also understanding it treats pain. And that's where the whole concept of the X waiver comes up, is by the Harris Act that was, governed all of this. You cannot treat a substance, you cannot prescribe a substance to treat that disorder. So for example, I cannot prescribe hydrocodone to treat opioid use disorder. And the X waiver waivers you from that law to allow you to use buprenorphine to treat opioid use disorder. But to use Suboxone, the combo Suboxone, which is FDA approved for opioid use disorder for pain, brings up a lot of medical legal concerns, and you'll have to check with your own medical legal department, etc. But most experts will recommend that you do not want to document or use Suboxone for pain. You want to use it for opioid use disorder. So the way we like to teach it and the way we like to do it in our system, what we found is, it's a very good question, because a lot of these patients with opioid use disorder will also have chronic pain. And it's first important that you need to be able to differentiate opioid dependence or tolerance from dependence and addiction, right? Because they're not all the same. So you can have a chronic pain patient who's dependent on an opioid, but that doesn't mean that they're addicted. So you need to be able to differentiate those patients first. And once you do, and you decide that this patient does have an addictive disorder, so they have a substance use disorder, opioid use disorder, then they also have an underlying organic pain syndrome, a cause of pain, cervical, whatever, some real cause of pain. You understand that buprenorphine as a partial agonist does provide some pain relief. Buprenorphine IV is used in the hospitals, Butrans patch, which is a buprenorphine, a monoproduct patch is used for pain. You can use it, but you want to understand that you're treating opioid use disorder primarily with your buprenorphine naloxone combination. And then sure, you can document that expected to also help with this patient's chronic pain. But the hardest part, and this is where you really want to use your clinical diagnostic skills, understand the patient, and this is sometimes where you might want to get someone else involved, like a pain doc or an addiction specialist, is differentiating true pain and pain syndrome from addiction, and that can be difficult. And if you can't differentiate the two, you should probably get some help on differentiating that, because you don't want to treat just pain with Suboxone. That wouldn't be an appropriate use of the medication.
Yeah, this is a really great question. I'm glad that someone asked this, and I'm going to echo some of the things that Tipu said. But what I want to emphasize is the scope of practice. I think as we move forward and try to really get primary care providers to start prescribing, we have to make sure that, and they have to make sure that they understand the scope of practice. If you're a primary care provider and you're doing pain management, then you are held liable from a medical legal standpoint for the scope of practice for pain, just as a pain doctor. If you're a primary care provider and you're treating someone with an opioid use disorder, you are held to the standard of practice, scope of practice, standard of practice as an addiction medicine specialist. Now, as a primary care provider, as a family doc, which I am, I'm really accustomed to this. We all are, to know what the standard of care is. And so you have to be aware of those things. So if you're prescribing bup to a patient for opioid use disorder, you need to make sure that the diagnosis is there. You can use the standard of care, which is a DSM-5. If you have a patient with a pain syndrome, then you basically want to practice within the scope of practice, standard of care for pain management, and it does not include buprenorphine. That's not the standard of care anyway. And so you just really want to be clear, like, which lane are you in? Now, there are a lot of people who have opioid use disorder who have pain. Great. Then you have to make sure they meet the standard of care for treatment for opioid use disorder, and that they qualify based on the diagnosis with the DSM-5. So basically, just stay in a lane. Like if it's one thing, it's another. If it's one thing, go in that lane. If it's pain management and there's no opioid use disorder, then you have to treat it for pain. Do the standard of practice, standard of care for that. Pain management, do all the different types of modalities that are standard with that. PT, whatever you want to do, but you need to pick a lane. You have to have a diagnosis. Is what I'm saying. Don't get caught up in some of that. Just figure out what the diagnosis truly is.
And that's great. And my recommendation too would be along the same lines is, as you're starting this and you're getting a medication assisted treatment program off the ground in your clinic, in your organization, et cetera, keep it simple. Right? Keep it simple. You want to manage the patients that have a clear opioid use disorder criteria. So just like Ako said, DSM-5, OUD, make sure they meet criteria for opioid use disorder. If they do, those are the patients you want to target. And I would even recommend, when you first start, as you're trying to get your providers and your staff, everyone comfortable, strict OUD. Don't manage the patients that are also dealing with the sedative hypnotic use disorder that are also on a benzodiazepine or a Z drug along with the buprenorphine product. Really focus on, which is the bulk of patients, focus on just the OUD. And that's the majority of who you're going to see. Start with just that, clearly identify opioid use disorder and treat that. And then the ones that are on this continuum of pain, the ones that are on this continuum of other substance use disorders, specifically alcohol use disorder and sedative hypnotic use disorder, those are the ones I would probably recommend when you're starting, send those to someone else. And get help from someone else on those. And then as you get versed and you feel more comfortable, definitely put on that hat if you feel like that's what you want to do and go down that route. But like Ako said, you're going to be held to that level of standard of care of an addiction specialist. So I would really recommend focusing on strict OUD that does not have a significant pain component or other central nervous depressant use disorder.
Can I just add in that being said, since I've been doing this for a while, I do have a panel of patients that do have opiate use disorder who do have severe pain. They've been in, horrible sort of traumatic accidents. It's just clear. They come in there in a wheelchair. I mean, it's obvious that they have pain, and but they have a documented opiate use disorder they've been using. Maybe they started on pills and then ended up using heroin. So it's clear that the diagnosis is there. Are they benefiting from pain management with the bupe that they're being prescribed? Absolutely. But in addition to prescribing the bupe, I also make sure that they see primary care and that they also have someone who's really addressing their ongoing pain with non-opioid treatments. And that's a really nice combination. You can sort of manage the opioid part if it's there, and then make sure you have, or maybe you're doing both, but it's really distinct in your notes that you're doing one and doing the other. The other is with non-opioids. I hope that helps.
We have another question related to behavioral health counseling, right? And so in the toolkit, there's a study cited, and what came up as some of the barriers with clinicians was the misperception that to do MAT, you must also have behavioral health counseling. And evidence shows that MAT is still effective without behavioral health counseling, though that is still the ideal, right? But if you don't have behavioral health counseling, doesn't mean you don't prescribe MAT. You could still do that. But the question to our faculty is, what are your experiences and opinions about using behavioral health counseling or not using it along your MAT services?
Yeah, so I think in my experience, I think that the addition of behavioral health, and the data supports this as well, is the addition of behavioral health is a very important fact, especially when it comes to trauma, et cetera, really CBT, et cetera. These methods of really working through these experiences are really important. So I think that I would not withhold therapy, medication-assisted therapy, for a patient who did not want to seek further behavioral support, but I always recommend it strongly. And depending on where you're at, you might have limited resources, but you can even just recommend a Narcotics Anonymous, some type of behavioral support, even peer-to-peer. And that's actually a federal requirement of buprenorphine dispensing as of now, prescriptions. Part of what you learn in your X-waiver training is you have to link them with some type of behavioral health support. And again, that could be as simple as Narcotics Anonymous or as complex as a psychotherapist, et cetera. But I do think there's a lot of value in CBT, coping skills, et cetera, that they'll teach you. And I think that's something that we should offer to all our patients. But I agree 100% that if I have a patient that clearly tells me I'm not going to go to NA, I'm not going to see a therapist, I would not withhold MAT from them. I would just document in my note, patient was offered XYZ behavioral therapy resources, was encouraged to attend them, and then go from there.
The only thing that I echo that. The only thing that I can add is that for the longest time, our core team, we didn't have, we would refer out to therapy and to our outpatient program. And I just recently decided to hire an AOD, which is the first time I've ever worked with an AOD, an alcohol and other drug counselor. And it's been really great to have this person as part of our team. We have a number of patients who are doing really well on bupe, who are really stable and have not relapsed on opioids, but they continue to relapse on other drugs. mainly meth, because it's pretty common here. And a lot of them are working because they're no longer, they're functioning now that they're off of, heroin. And so they're working, so they find it really challenging to see our therapists or go to programs. Sometimes they do NA or AA. But now that we have this AOD, it's been really helpful to have them come in and sort of dovetail our visit with some work with that counselor. And so this is sort of one way that we've worked around this for people who are kind of resistant, like, I don't have time, I'm working, I'm stable now on Butte. So we've actually added it to our clinic appointments for them, and they have found it really helpful. I'm noticing a little bit more improvement for them.
And one last thing I would add, and this is relatively new. I'm part of an advisory committee that's working on this, all disclosures aside, so I'm not going to name any particular products out there, but there are smartphone-based programs out there now that provide CBT, and there was one that was recently FDA approved for CBT use in opioid use disorder, and it also provides CBT, but also contingency management into that. So there's a few different ones that are out there, but there are apps that are approved. Depending on your insurance and your payer, you could prescribe these apps to the patient, and they can do their own behavioral therapy, if they're busy, et cetera, working, they can do this on their own. I had a patient who was a lawyer who just had no time to attend anything, and I did prescribe one of these apps to him, and he has found that it's been quite useful. So there's also new technology coming around to provide different approaches to behavioral therapy for those that can't make it in.
Yes, and one thing I noticed across the organizations was there's a lot of opportunity within California to use telehealth, and the data shows it's underutilized, but it's very effective. So for those organizations that don't necessarily have behavioral health services already integrated, that there is an opportunity to leverage telehealth, whether it's through apps or some kind of other service. Great. So my final question to you guys heading into the end is, where are you going next? What do you hope for? What do you want? What do you need? That's a lot of questions.
So I guess I can go first. I was waiting for Ako to go, but I think he's looking at me. So for us specifically in our system, two big things we're trying to do now. So one, we've started a primary care addiction medicine fellowship, ACGME accredited fellowship. So we now are training fellows in the subspecialty of addiction medicine. But we're focused on a primary care addiction medicine fellowship. So we want our fellows to be a primary care doctor of some sort and allow them to take the specialty training they get and apply it to their clinical practice when they go out to be primary care docs still. So that's one thing we're focusing on, is our training of docs to do primary care and addiction medicine. But in a system standpoint, we have a lot of satellite clinics. So we have multiple clinics that are associated with our bigger healthcare agency. Our next step now is to get at least one or two key players at each of those clinics to take on medication-assisted treatment so that instead of referring them into our clinic, they can manage it in their primary care home. So really from a patient-centered standpoint, they don't need to come to the big medical center or the big academic clinic. They can go to their medical home that's right across the street from their clinic. So that's kind of our next step as our organization, is we're trying to develop and roll out MAT amongst our satellite organizations. And the barriers we're running up against are the same barriers we faced when we started here. Mostly, again, stigma, provider, misunderstanding, etc. So we're kind of going through all the same steps, again, that are outlined in this toolkit of how to kind of break those down as we move forward.
So for us, so yeah, teaching, education is probably the one that we're doing mostly. We have fellows now through UCSF who are rotating through our organization, and we also have we have a NP residency, and so part of their residency is to rotate through the MAT clinic. And we're thinking about putting together sort of like a nursing training so that nurses can become more versed in MAT, and nurses who want to work in the outpatient setting. So it's really around using what we've done here in the organization and doing more training and education. The other thing is that I mentioned earlier that in our organization we have a behavioral health component, and so medical director of that program, the residential programs. And we find a lot of the clients who go into residential program have never heard of MAT options for alcohol or opiate use disorder. And so it's still crazy when I meet someone who's like, no, I've never heard of that before. I've never heard of Suboxone. And who's been using heroin for 20 years. And so we still really feel like a lot of patients just don't even know what's out there. So a lot of it's around figuring out how we can, in a sort of non-biased way, introduce people to MAT, where they can sort of see it as the tool that it can be to help them move through their recovery. So those are, I would say, the big things here for us. And I wanted to actually mention something earlier when we were talking about the standard of practice. And I wanted to refer to, for us, what we use for standard of practice for MAT, for me, because I'm boarded in addiction medicine, so it's really important. But even for primary care providers who are doing this, who are deciding that they don't want to get that certification in addiction medicine, the standard of practice that I use is from SAMHSA. It's from ASAM. I'm sorry. You just go to the ASAM website and just look for standard of care. It will tell you exactly, just point by point, what's expected for you to do when you're prescribing MAT. And most of it's basic, and you're going to do it just by seeing a patient and just what you typically do. But there are some things there about making sure that the screening tools are done so that there is a diagnosis, and then also some of the diagnostic testing, like urine drug screens, that may support your diagnosis. So I think that's a really good tool for all of us to just know what the standard of practice is, standard of care is, and so that when you're doing this, you can do it and feel like you're doing it like the other clinicians are.
Yeah, great, thank you. And I know the California association related to that has a lot of training and mentoring towards that standard of care. So that's another resource for everyone to go there. Okay. So I wanted to say thank you to our faculty and to Tipu and Ako for sharing your expertise and your insights and what you're doing. And thank all of you for your questions. Again, go to the toolkit for a little bit deeper and more specific actions. And if you have any questions, either reach out to the informants or reach out to me, and I'll get you in touch with the right people that can answer that, or get in touch with CIN. See, so I'll pass it back to Marie.
Yes, thank you all so much, and thank you to both of our presenters. It was great to have you on and to hear about all of your great work. So I'm going to just launch a quick poll, which is just an evaluation to hear from all of the attendees regarding how the content was today and how it can support your improvement efforts back home at your organizations. So a few upcoming events that CIN is hosting. We'll be having a webinar on understanding risk-based payment models. That'll be Thursday, February 28th from noon to 1. We're also launching a social needs screening and referral case studies project. That'll be made available sometime by the end of March. So look out for more information and to register for those events on the CIN website, www.chcf.org/CIN. This concludes our webinar. Again, this webinar was recorded, and we will share the recording with all of you. Please feel free to share it widely among your networks. Thank you all again for coming, and I hope everyone has a great afternoon.
Thank you all.